Good afternoon, everyone, and welcome to this month's HIMSS-SIIM Enterprise Imaging Community Webinar. My name is Jason Nagels, and I'm the Clinical Program Lead, or Clinical Program Manager at HSTRS, and have the pleasure of serving as today's moderator for the Encounter-Based Imaging Workflow webinar presented by Kevin O'Donnell and Ken Persons. Kevin O'Donnell is a Senior R&D Manager at Canon Medical Research USA. He graduated from the University of Waterloo and the University of British Columbia with engineering degrees before joining Toshiba Medical in Japan. As an enthusiastic believer in the benefit of standards to medical imaging, he has represented Canon and chaired a variety of committees in DICOM, IHE, and KIBA. He is the lead author of the IHE Encounter-Based Imaging Workflow Profile. Ken Persons is the IT architect for Mayo's Enterprise Imaging Project. He graduated from Iowa State University and University of Minnesota with degrees in electrical engineering and worked at IBM on data communications, networking, and medical imaging projects before joining Mayo in 1994. Ken is also an enthusiastic advocate for the use of standards in medical imaging and has seen the benefits that come from it. He's an active member of SIIM and co-chaired the HIMSS-SIIM work group on standards and interoperability. Ken was a key contributor to the IHE Encounters-Based Imaging Workflow Profile and is the new user co-chair of the DICOM Strategic Committee Working Group 10. After this presentation, we'll be engaging in a question and answer session, so be sure to engage through the chat window at the bottom of the webinar control panel. With that said, let's begin the webinar. Welcome, Kevin and Ken.
Great, thanks Jason. Thanks for the introduction, and make sure this is presenting okay. Everyone see that all right?
Yep, it looks good.
Okay, cool. Ken and I would also really like to thank SIIM for both for inviting us to make the presentation, but more importantly, the material we're going to present today was initiated and significantly informed by presentations at SIIM a couple of years ago, and by the white papers and the work of the HIMSS-SIIM Enterprise Imaging Work Group, that they both identified and characterized the needs and the challenges of encounter-based imaging. So this work here today is here because of that work. So, thanks to SIIM for really getting things pointed in the right direction, and hopefully this will represent a good step forward on the product side of things. So Ken and I will be tag teaming a bit on the presentation today, and we'll try and describe how to address encounter-based imaging workflow. So the first element of that is, well, what do we mean by encounter-based imaging? I imagine everybody on the call is familiar with the concept of enterprise imaging, sort of taking an approach within the healthcare enterprise to take a unified approach towards imaging and addressing all the many different uses of images in the healthcare system. The bulk of that historically has been what we call order-based imaging. And so this is your traditional, the things that go on in radiology and cardiology departments and a little bit elsewhere, using big typical modalities like CTs and MRs and mammo and echo units. But now more and more, part of the thing driving enterprise imaging and the use of VNAs and the like is the growth and recognition of encounter-based imaging. This work is done in dermatology departments, wound care, burn units. You'll notice there are 5 times as many et ceteras on the left as there are on the right. This really is the long tail of imaging. And it's making use of tablets and cameras, point of care ultrasound devices. And really the defining characteristic of this is that the imaging is captured in the context of an encounter between a patient and a care provider, typically without an imaging order. And so as you'll see, we get to in the coming slides, context is everything. Context is very important. The order carries the context with order-based imaging, and we really need to collect and record the context when we're doing encounter-based imaging. So at this point, we'll hand over to Ken to talk through how EBI appears in practice in healthcare.
So thank you, Kevin. So in practice, I guess we're going to focus on several kinds of modalities, point of care ultrasound, is the first one, and then cameras, handheld cameras and so forth, and then endoscopes. So point of care ultrasound devices, as many of you realize, have become proliferate. It seems like they're popping up all over the place. Recently, we've had some that are devices, that applications you can put on your iPhone and then run from the cloud. It's just, there's just a lot of uses for ultrasound. Next, there's a, so there's description, I guess. Ultrasound, it's used at the point of care as a tool. That's why there's no order. The tool is grabbed for use. Usually it's for procedure-based or evidence type of imaging, and sometimes it's used for diagnostic imaging. Examples are to guide the placement of a catheter, or in the emergency room, it's used to assess for things like internal bleeding or soft tissue infection, thrombosis, gallstones, etc. So the next slide shows just some pictures here taken at Mayo. The one on the right is a class where they're teaching the use of ultrasound for guiding injections, and the others are just in applications in the rooms with patients there. But we have hundreds of these machines all over the place, and it was quite an ordeal when we first discovered that, even just to identify them all on the list and where they all are, who owns them, and how to get them all hooked up. So next, medical photography is another big area where encounter-based imaging fits, and cameras are used in lots of ways and lots of practices. So next, so medical photos, they're acquired by a variety of departments, usually used for evidence imaging, but sometimes for procedural purposes. They're used to document, it's like the evidence in wounds, burns, bed sores, to document before and after surgical procedures. Sometimes the photos are restricted or of a sensitive nature, and so there are some special requirements around medical photography that need to be dealt with when you're thinking about collecting the images and putting them inside your systems for distribution. Next. So this is just a picture of an iPhone, an older one, shows how dated this slide is, with a dermoscope attached to it, taking pictures of skin for dermatology. And endoscopic procedures is another area. So endoscopic is kind of interesting. There also video comes into play here. Next. There is the endoscopes, microscopes. They're used to visualize in surgical procedures, to document, what the findings were during the procedure. It's usually not ordered in advance, but sometimes some of the images that are acquired are important to make available in the patient's medical record. Examples are colonoscopy, orthopedic surgery, and arthroscopic procedures. Next. So this picture was taken, this was an ENT procedure back in 2015. And what's neat about this is this was a CT scan that was originally done, and you can see in the background in the middle on the monitor is the CT image. It's kind of looking blue and white sort of light in the 3 cross sections, and then there's an antenna over the patient. You can see with the yellow with the antennas on either side, which is geographically locating where the endoscope is in the patient, and then there's the endoscope itself and the visualization there. So the surgeon, ENT surgeon here, can see where they are in 3 dimensions based on the CT image as well as looking at the endoscopic images. But during the procedure, they can capture images, video clips or still images. And it's important to have some of those images saved off so they can review that later, the results of the surgery, show the patient, have it documented in the medical record. So many ways these kind of imaging is acquired that doesn't have an order with it, but it's used as part of a procedure, and typically in the past has not been well cataloged, not well defined in the medical record, and so forth. Next. So the EBIW profile, encounter-based imaging workflow profile, what it was trying to do was address medical imaging performed outside the context of an ordered procedure. There's been 2 passes. The first pass came out last fall, and it was focused on point of care ultrasound. The second pass came out this spring, which enhances the profile to include what we call lightweight devices. So lightweight devices, it's lightweight in 2 ways. One, most of them are lightweight to physically hold, like iPhones and so forth, but also the lightweight devices use lightweight protocols, the web services, as opposed to the more traditional DICOM protocols, as you'll see in a bit here, to communicate between the systems that they're capturing information about the images from and delivering the resultant images to. So Other motivations of the profile are to capture and record consistent and predictable metadata. So one of the problems with images when you just store them away and whatever you've got is that there's usually no metadata around them, and when you go to collect them and use them later on, it's hard to know what they're of. So this is the attempt here was to define what metadata is important to have with the images that are acquired and store them in a predictable way so that you can search on them later. And in that process, minimize manual data entry. I think most of you who are involved with this kind of imaging and look at how data is acquired, there's a lot of manual processes in place today where they're hand typing patient names and IDs and using drop downs and stuff. So getting away from that and then creating more efficient workflows and really based on using standard interfaces. So we've always been about standards, and I think it's really important to try to apply standards to this space as well. So RESTful web services, which are a recent addition to the DICOM standard, recent meaning a number of years now, but they're all available to do the same kinds of things that we do with normal radiology imaging, like the modality work list, the storing the images and the queries and the retrieve. And then managing access for the images as part of a well-knit medical record. So medical records traditionally have a reputation of not having this kind of imaging in them, but I think that's changing these days as more of the medical record integrations that are put in place are providing the ability to either connect to viewers that have these images or integrations with VNAs that allow them to index and show that there are images available for those kind of procedures. And finally, to facilitate billing and analytics. Analytics is the most recent one. There's a lot of interest these days in collecting these images for, say, dermatology and applying an AI algorithm to see if you can identify a certain kind of a mole or skin condition using AI as a way to aid the dermatologist or the whatever area. It's just an overflow of requests coming to us for imaging data to do these different kinds of AI projects. Next, so what's the harm if you just don't do anything? Well, first of all, manual entry hurts quality as well as efficiency. We all know that. The patient's imaging record is fragmented across departments, so if you don't have an enterprise solution in place, a place for them to put the images, most of these departments don't have the resources, the systems. They'll buy something from vendor A, B, C, D, all the way through Z, and you'll have your data stored in those various systems in various departments and won't be able to get access to it from the medical record or much less from any other place. Images are commonly printed if they're needed then and scanned into the EMR. This happens a lot with different kinds of data sets that there's no easy way to get in the EMR, but they need them in the medical record. They'll print something and scan it and then have it at least accessible from the medical record. But of course, there's no metadata around that. It's just a scanned thing. And then within the EMR, we commonly find images lumped under a media tab without any really detailed information about what the images are. That's not necessarily placing blame on the EMR. It's really the acquisition process and the data management that's sort of lacking, that the information is not there for the EMR to be able to categorize and properly show. So, and sharing them between affiliated hospitals is limited or non-existent of these type of images. And the images are not available even within the hospital for the care team. And time is lost to the awkward workflows and data captures that are put in place to handle the one-off solution for this department or that workflow.
So the question now comes up, okay, so what are we going to do about it? We had a good description of the nature of the problems, and we had a sense that the standards were adequate to address it, but what we really needed is to work out how to put those two things together. And really, that's the typical job of IHE. That's what IHE does. It tailors and tests standards. There's links there for folks who aren't familiar who want to dig in a little deeper. But basically, when you've got a specific use case and you've got existing standards, but you need additional specification to talk about how to apply those standards to that specific use case, in many cases, taking away a lot of the optionality and highlighting specific optional features that become mandatory in those use cases, that's what an IHE profile documents. The second thing that IHE brings to the table is the testing part, which is what happens at these Connectathon events. And you can see a picture above that it's really enormous cross-testing events with, literally hundreds of engineers, many different systems. And IHE is spread across multiple domains. In this case, this work was done within the radiology domain. If people aren't familiar with the terms, just a few quick ones that we'll be using in the rest of the presentation. So a profile is an implementation guide for addressing a given use case. It's specifications on actors, and it specifies transactions, which are these standards-based messages that go between the actors. So an actor is a generalized real-world system or component thereof. So you'll see a number of our actor names look a little bit abstract. Later in the presentation, Ken will show how those map back to systems that you actually go out and buy. But we don't usually talk in terms of PACSs and VNAs. We'll talk in terms of image managers, et cetera. And then the transactions are these specified interactions between the actors. A couple of EBIW terms that we're bringing in is, well, what is an encounter? So we've described it in terms of an interaction with a care provider. So you're interacting, it may be with a dermatologist, it may be with a nurse, it may be with any hospital staff. And in the context of that interaction, you're capturing images. Usually this is in the context of a visit to a facility, but not necessarily. Within FHIR, they have a multi-layered definition, but we can get further into that if people are interested during the question period. The other important term to kind of log away is this encounter manager. And so this is one of these actors that coordinates the encounters and the associated data. So an example of where you might see that is a practice management system, or it might be an EMR console in the dermatology department. But this is one of the coordinating actors that you'll see is pretty central. The information model is adapted from the typical order-based models. So as before, at the top, we have the patient, and a patient can have 0 or more visits. During 0 or more visits, they may have 0 or more imaging procedures, which result in studies which contain series. And we've kind of inserted the encounter in between the visit and the imaging procedure. So during a visit, say to a hospital, you may have multiple encounters with various care providers, and during those, you'll be performing sometimes 0 or more imaging procedures. And so each of these layers has a key identifier so that you can refer to a particular encounter or imaging procedure, et cetera. But we want to highlight here, you'll see a session number coming up again and again. It's really been adopted as the primary link between the EMR and the imaging record as it's held in the enterprise image managers. Typically it's linked to an order, but we figured there was no reason to break that association. And so in this case, the session numbers can also be associated with encounters. And so that lets you use the same mechanisms that you get to order-based images to also get to encounter-based images. You can have multiple procedures during an encounter. So if you only have a single procedure, you're only going to have a single study. But if you do multiple different procedures, you could end up with multiple studies. But typically, if you're doing a single procedure on multiple body parts, you'll see those manifest as multiple series within the study. And then finally, the encounter is also the level that you'll link across to clinical notes and other medical documents that are also captured during the same encounter. So when we started working on this, we've been building on scheduled workflow as the basis for the order-based imaging. This started up back in the very end of the 1990s and across the early 2000s. And this is why really radiology workflow stabilized pretty well in the early 2000s. We worked on standardizing the order transcription from HL7 orders into DICOM, on getting uniform deployment of modality work list across all the modalities, which really was a big step forward in terms of making sure that the demographics and procedure data that you need are there, but make sure it all happens fast and error-free, which basically means no typing. You know, that when you've got people typing in patient names and patient IDs, A, it slows you down, and B, it sets up lots of workload in your exception queues. And so anything that can be digitally transferred is. And then finally, the image headers need to be consistently populated, that if you can provide a good, reliable feed of the metadata, then make use of that and make sure that not just for the modalities purposes, but for the reading workflow downstream, that everything is consistently populated. So EBIW built on that foundation. We borrowed the basic concepts around accession numbers as linkages between the imaging space and the rest of the healthcare space. The metadata query and standardized storage also were sort of the basis for this profile. We changed things up a little bit. We introduced this new lightweight device category that Ken was describing earlier. Those transactions are based on DICOMweb, which, as Ken says, has been around for a while now, and a lot of the PAC systems are able to do DICOMweb pushes and pulls and the like. And we added a result notification, which we'll talk about in a moment. We skipped the order because it takes up extra time for the clinician to have to place an order in order to do the imaging. We let them just get going on the imaging as quickly and easily as possible. And we didn't incorporate the modality performed procedure steps or the storage commitment. Now, those are both, you could use those, but we decided to keep the bar as low as possible to let EBIW be as easily deployed as possible. If it turns out those are significant needs, they're entirely compatible with the EBIW workflow. And then finally, the whole point of the profile is we want to drive vendor convergence on usage of specific data elements. The whole point of having an IG profile is the vendors are each doing things a little bit differently, and so you don't have standardized out-of-the-box solutions. So what's the key to making this profile work? Well, since it's no longer the late 1960s and it's the late 20-teens, and if you've been paying attention, you will know now that the answer is metadata. This is the hub of this whole profile. By metadata, we've broken it down into 4 categories of metadata. The first layer is the patient metadata. This is your typical demographics, your name, your date of birth, your age, etc. There's the encounter metadata, which describes which department is the encounter taking place in, who is the physician, what's the specialty, what was the admission ID and date and time, reason for admission. The procedure metadata, so about the specific imaging procedure, what modality was used, what body part are we looking at, what's the reason for imaging, and there you see the accession number. And really, this is what turns this JPEG into a medical document. If you have a JPEG, it's an array of pixels. But if you can't tell the clinician, what patient am I looking at? When was this taken? What body part is this? Why did you take this picture? You know, what are you trying to determine here? It's just a picture. It's just pixels. The pixel metadata is, of course, useful for display, and so that's already pretty well managed. But it's the top 3 layers, which is where our attention was put. And the reason for that is you need this to be able to manage these images. As Ken, I'm sure, can attest, we're talking about millions and millions of pictures. In fact, I think their total archive is in the many billions. And if you want to manage that amount of stuff, it has to be properly labeled. And in particular, if you're trying to find and use particular images out of that enormous archive, it's just undoable without good sets of metadata. So the way this works, if you imagine the case of point of care ultrasound, you may have a clinician in the ER, they're seeing a patient and they decide, you know, there's no order here. They decide I'd like to evaluate, you know, for fluid in the abdomen. And so they pull over a point of care ultrasound card. They may then scan the wristband, which gives perhaps a patient ID or an admission ID. And if this were the normal order case, the modality would be querying a scheduled work list. But there is no risk with a scheduled work list. And so this is why we've introduced this idea of the encounter manager, whose job is to marshal and provide all of this metadata. So by sending that patient ID or that admission ID to the encounter manager is able to provide back a full set of, here's a full description of the patient, here's a full description of the admission, etc. So that where that encounter manager gets that information isn't specified in the profile. We decided that there were actually a number of perfectly valid solutions, and we didn't want to get into trying to standardize that part at this time. So the encounter manager may be a component of the EMR, in which case it has internal direct access to all that information. It may be using an IHE profile like the patient administration management or patient demographics query. It may have access to some MPI with extended metadata. Various sources, but it gets provided back to the modality so that when the modality goes ahead and scans the patient, it can then combine this metadata just like it would have gotten from a modality work list together with the image and store it off to the PACS. So for a conventional type device like an ultrasound, that's a pretty conventional store. The final gap in the workflow here is that because there was no order, the EMR still doesn't know that images were actually acquired. In the case of an order, it has something that it can use to go look for those images in the enterprise image archive. So we've included a notification transaction that's based on an HL7 ORU, which provides all the details that the EMR would need. Now, in our typical IHE fashion of not calling it an EMR, we've called it a result aggregator. So this is the whatever device has responsibility for collecting new results and aggregating them into the record. It could be a component of the EMR, it could be a front end on the EMR. So not calling it an EMR gives that flexibility, but and typically we'd expect it to be in the EMR. It's given enough information. Some EMRs like to backfill an order, so they will auto-generate an internal order for unexpected imaging, and we've made sure that there's enough information in the notification that they can do that, although the profile doesn't require them to actually do it if they don't need it. Now that was a bit subtle, but you'll notice we've switched modes now from the point of care ultrasound. All you really have to do is swap out a tablet for taking pictures. You might be evaluating an injury. But things are a little bit different. So if we shift this off to the side here, this is now using DICOMweb for those two transactions, for the query and for the store. And so for this get imaging context, the tablet is sending essentially that message you see at the top. You'll notice in the upper left corner, there's the admission ID, and it may indicate that it's a tablet number 1 in the dermatology unit. What the encounter manager will send back is the collection of metadata as a JSON bundle. So, there's a little bit of parsing required, but you can see the patient name is John Smith, the date of birth is July 1st of 1967, et cetera. And so this is the information that would normally come back in a work list. And then when the tablet needs to store this, the DICOMweb stow message, again, looks like an HTTP. You see its application, DICOM plus JSON. It's essentially copy-pasted most of that JSON bundle that it got in the query. You can see the first few entries there. There's the name, the ID, the date of birth. And they've supplemented it, likely with a local interface on the tablet, to indicate that the body part examined was the calf and that it was the right calf. At the bottom, the part of the payload of the message, they've simply inserted the JPEG directly into the DICOMweb transaction. So it makes things relatively easy for devices to make use of this. So moving on to a third possibility, you may have a camera which is also, using proper cameras, proper lighting. Perhaps you're taking mole pictures. That in the same way, if you brought somebody into the CT suite and you asked them to point at the modality, most people would point at the gantry. And in fact, from DICOM terms, the modality is the console. That it's the operator console of the CT that does the modality work list query and forms the images up into DICOM and pushes them off to the archive. That the gantry is a proprietary sensor that uses a completely proprietary connection to the console. So in the same way, we would expect that for pictures, there's a number of vendors out there who've developed laptop software for essentially doing the same thing. They communicate to a camera using Wi-Fi or by moving SD cards. We don't really care. That's the sensor. It's doing its job. As long as the images get into the system that can combine them with metadata and store them, we're all set. So really, you'll notice in this last diagram, we've been talking through, there are basically three interfaces in the profile. There's the get imaging context between the modality device and the encounter manager. There's a store image interface to the PACS, and then there's this notify image interface. And so there are 5 lines in the diagram because 2 of those interfaces have 2 flavors. In the case of get imaging, you can have the traditional DICOM or the DICOMweb. In the case of store, also traditional DICOM or DICOMweb. And then in the case of notification, that's an HL7 ORU message. Mostly we were trying to make sure all of this works in existing environments. The main addition you'll need is an encounter manager. And that in the future, you could imagine some of this stuff would also be doable with a Fire interface, but we're still sort of working through working Fire up its maturity model. So at this point, I'll hand it back over to Ken to talk through a few more of the details around the metadata.
All right, thank you, Kevin. So we're going to dive in just a little bit here into the EBIW, what the actors and transactions do, and look at how this might look in the real world. So we tend to think here, I guess at Mayo, we've been working with DICOM images for years and very familiar with the DICOM headers and all that stuff. But what is the information that's in those headers? What's actually being communicated on these transactions? So with that, we're going to look at 3 parts. We'll start with the get encounter imaging context request, which comes from the acquisition modality or the lightweight device up to the encounter manager. So these are the key attributes that are included, and we've shown here the DICOM tags that are relevant for those. And we've also broken it down to match what Kevin described earlier in the metadata description to organize it by patient metadata, encounter metadata, and procedure metadata. So the patient metadata, the patient's name, ID, the issuer, the birth date and sex comes across. That's some very important information so we know who the images are for. And with DICOM, we have an encoding place to put those pieces of information to include with the images. The encounter goes into the institution information at the minimum, the name of the institution, its address, department, admission ID. Now, these are things that we traditionally don't think of in the imaging world. We're down below this. Admission ID is something that happens in the EMR, but it is an important piece of information. And if it is included with the images, now we have a way to tie back the imaging that was acquired here back up with that encounter or visit that the patient made, which is one of the gaps we still have. When you collect images and just tell the EMR about some images, yes, it can make a link to those images and put it in the EMR, but it really is disconnected yet from the visit. And that's something we're trying to work to resolve. And then down in the procedure metadata, the accession number, again, as Kevin mentioned, is the key. We're kind of reusing that. We're using that from the order space SWF as the key that radiology always used to tie the reports and the images and the procedures together. And of course, the issue of accession number is important to go with that, so that the accession numbers aren't necessarily unique. We try to make them unique, but they should be unique across an issue, or not necessarily, but not necessarily within a given accession number environment. So study instance UID is also communicated. So all modalities pretty much have a way to generate a study instance UID if it's not there, but we would prefer to have that study UID come down with this procedure that's going to be performed. It's been assigned, it matches up with this admission ID and accession number and so forth. And I'm not showing here the specifics of the modality work list query versus the UPSRS, the RESTful query, but either way, the same information is communicated on those requests. Also not shown here is a bunch of optional fields. You know, the reason for the visit being one of those. There's about 40 or 50 optional fields, each of which has a DICOM tag, which could be communicated but are not required by this particular profile. So that's we've looked at the interface now between the modality device and the encounter manager to collect this kind of information about the procedure that's about to be done. So next. So now we've made the images, we've captured the images on the patient, and we're going to produce the result, which in this description will be a DICOM image object. It's a DICOM wrapped JPEG, or it's an ultrasound that is natively a DICOM. And we're taking that same information that we acquired from the encounter request and encoding it into the image header, and then adding a few other pieces of information that may not have come across at the encounter. So at the point of the encounter request, we know the patient, we know the institution, we know the admission ID, but if you go to the next page, we don't know some other things like what was the procedure that was done, a description of the procedure, and the study date and time that's actually happened at the device itself. So you can see in the right-hand column there, source of value. We try to carry over anything that was from the imaging context query and load it into the image header in the appropriate place. But also we'll need to have some other parts and fields filled in either by the application. Some of this can be done automatically using a date time mechanism. Others will require some kind of a manual entry or an entry mechanism. Study description is the big one. Body part examine is probably the other big one. Those things are usually known by the order in the SWF. They come across saying, I want a CT exam of the head, and the description comes with that, the body part comes with that. We don't have that luxury here, and we don't have anything that really knows that except the person doing the procedure. So it is a point at which we need some kind of a manual entry or process to try to fill that in. As much of that as possible, though, could be filled in by the application in the acquisition modality or the lightweight device. So so in the result here we have is a DICOM image with the appropriate meta header information captured and encoded in a predictable way with predictable values. Next.
Yep, and actually just to jump in on one point. We wanted to keep this fairly easy, and for the modalities, we could imagine that as the encounter managers get more clever, if they know that you're in the ophthalmology clinic for a follow-up of your, on your left eye, they may be able to offer a pre-populated body part that the operator can either just accept or change. So, when systems are clever, we may be able to even minimize some of the fields that would normally be entered. The other aspect is we didn't want to raise the bar too high, so we didn't require that they put in coded values for anatomic region, primary anatomic structure, reason for performed procedure. But those are going to be really, really useful for managing and later searching for this data, as well as driving things like AI and analytics. So advanced modalities will provide those optional tags, but it's not a baseline requirement for the profile.
Yep, thank you, Kevin. And finally, the third interface that we talked about was the HL7 interface from the image manager, which has now stored these objects, and it wants to tell the results aggregator, typically the medical record, that we have images available for the patient, and uses a traditional type of an ORU request to communicate some of that same information, the patient information, date of birth, visit number, the procedure code, and there's ways that this stuff is calculated. So procedure code is an order thing, but what we're trying to do is emulate that. At this point, we should know the procedure that was done, and if we don't have it mapped to a particular code or number, there are ways to derive from the modality and the body part that was entered a procedure code that's descriptive and useful. So this table here maps the information, again, from the DICOM image header to the HL7 ORU elements that are communicated back to the results aggregator. So now we've looked at the three transactions in a little more depth. We can look now from a different perspective in a flow diagram and in the real world, what are these actors? Where do these actors live? IHE describes things, as Kevin mentioned, in terms of actors and transactions. It really is not trying to dictate what any product uses. An EMR, for example, could probably have all of these actors inside of it if it wanted to build itself that way. Or it could interact with a VNA, and then the VNA would have certain actors like the image manager. This flow diagram shows how the flows connect to the sequencing of events, I guess. I guess one thing to point out here is the encounter manager in the upper left here, and then to the left of that is the result aggregator. There are shared boxes where it's also shown as patient encounter supplier, patient encounter consumer. We haven't talked about those actors. They come from another profile, the PAM profile that Kevin mentioned. When he was talking about the encounter manager and how it works, he said it has to relate to some other things to get other kinds of information about the encounter that it may not know. So this is just one of those ways it could be connected up. In this case here, it's a feed of the patient information of the patients that are known coming in for encounters. But anyhow, maybe stand that for a second. Back up for a second there. So patient arrives, doctor begins and then at that point, there's the get encounter message flows, and the images are acquired at the acquisition modality. Images are then stored to the image manager archive, and then you can see on the far right, the archive sends a message all the way back to the result aggregator using those transactions that we just walked through, either the DICOM traditional transactions, HL7 traditional transaction, or the DICOMweb versions. Next. So these couple diagrams just show conceptually where do these things live. So this isn't where they have to live, but typically an EMR might have the encounter manager inside of it and the results aggregator. And in which case it already knows, as Kevin mentioned, the encounter manager may already know some things about the patient without having to have an interface to get the visit information, for example. And what's exposed between those red circles, which are the real world actors, the ultrasound device or digital capture system, the VNA, the EMR in this case, those are 3 vended products, is they just have to expose the appropriate interfaces to be able to communicate those 3 kinds of protocols, the ones that they're responsible for, so that we can talk between those systems. This just shows 3. 3 systems involved. Here's a 4th system with the EMR in this case here has the results aggregator role, but not necessarily the encounter manager. That could be an information system, whatever information system, a departmental information system, an image management system. That for the enterprise, there's different places you could place that. In any event, if it is placed outside of the EMR, there's probably some kind of a communication between that system and the EMR in order to know the patient and a little bit about the visit and the schedule. So now moving into the lightweight modality, it looks exactly the same. The only difference is we're using the UPS, the RESTful services, in the case of Modality Worklist, and the DICOMweb RS web interface in case of storing the images. So the next slides look exactly the same. They could be the same players. The EMR, a photo capture device. Now I guess that player is different. It might be a mobile device, but it actually could be the ultrasound device too. In the future, there might be a time when we don't use those traditional DICOM protocols anymore and everything is converted over to a DICOMweb. But the DICOMweb is really nice for the lightweight type of physically lightweight devices to work with. And then finally, there's the separate capture workflow. This variation is for the case where Kevin described that there could be a camera that acquired images on an SD card or transmitted them via Wi-Fi. So the camera is physically separate from, as Kevin described it, the modality. The modality is the thing that interacts with the encounter manager and the archive and creates the data set and manages the data set and the procedure. So it looks the same, it's just that we have a different actor added there, a capture device actor, and talking to the lightweight modality. Next slide.
Oh, and just one point to highlight here. You'll notice on this one that the acquisition of the images happens before the query for context. So in the previous ones, we queried first and then we acquired and put them together. But as long as they both get put together before you send to the image manager, it doesn't really matter. So if it's more convenient to pick up and start acquiring before you finish identifying the patient and querying for the metadata, that's workable as well.
Yep, thank you, Kevin. And this just shows, again, a conceptual picture of systems that you might buy, like an external camera from Best Buy, image import software from various vendors that provide that, the information system which might provide the encounter manager, and also the web services appropriate for communicating that, and then the VNA again, and most of the VNAs today support the DICOMweb services, so that's something that should work as it's already built. Next. So just kind of looking back, this is my last slide. And by the way, I should just mention to you, it may have been obvious that Kevin and I are not in the same office. He's out in California and I'm in Minnesota. So we're just trying to work this together. It's going okay. But I just wanted to summarize what we've learned a little bit here. And again, something that Kevin described in the beginning, which I think is really important, is that this encounter-based imaging workflow profile builds on the scheduled workflow profile. It takes advantage of some things that have worked well in the radiology environment, the DICOM modality work list, the well-defined DICOM image header structures, the use of an accession number as a key, and then the DICOM store and query retrieve services, which are already well-defined. It adds to that the DICOMweb for lightweight devices. So now lightweight devices like iPhones and iPads and other things can plug and play in this DICOM world, which has been more the traditional environment of the heavy iron, the CT scanners and the MRs of radiology and cardiology. But to note that capturing and leveraging metadata properly depends on having a clear information model, which has been described here, the model Kevin went through, a query model, etc. And by storing photos in DICOM wrapped pre-existing infrastructure that was laid out for scheduled workflow, and the other DICOM modalities can be leveraged in these lightweight environments as well. One of the discussions that's gone on in the industry for a long time now is, do you store JPEGs as native in their native format, which is JPEG, or do you wrap them in DICOM? And there's pros and cons, and I've been involved in discussions. Here, I am a big fan of wrapping them in DICOM, and I'm not trying to tell you you have to do it that way, but it's worked very well for us. We ingest about 250,000 medical photos a month, yeah, and they're all DICOM wrapped, and they all are searchable and available in the EMR today. And that's really been it's worked out well for us. If you don't choose to do that, if you choose to store the JPEGs natively, you'll still need to solve the problem. You'll need to invent the information model, a query model, and then you'll be able to store those images away in their own way, under their own model and index and so forth. So that's the end of my part. I'll turn it back to Kevin here to finish up the last few slides, and then we can open up for some questions.
Sure. And so one of the other sort of benefits of IHE is, there's a long set of complex specifications that are inside of the profile, but to facilitate the purchasing process, the vendors on their side state conformance to one of these profiles in what's called an integration statement, which we'll look at in a moment. And then on the hospital side, you can use those profiles as part of the discussion. So, for example, asking, does the EMR implement the result aggregator in the EBIW profile, is basically confirming that the EMR is going to be able to receive and process the ORU notifications that are getting sent out. Similarly, if you're writing up RFP language, you could put in a requirement shall support the EBIW profile as the acquisition modality actor. So that would be to make sure that your new point of care ultrasound system is going to be usable for encounter-based workflow as well as order-based workflow. So some of the ways that you confirm product conformance, one is the integration statement. That's a formal piece of product documentation. If you find it's not living up to what it's stated, you can go make your complaints to the FDA that, just like any other product defect, that's something we take seriously and try and make sure we're working as best as we possibly can. Checking Connectathon results is also a good thing, and I'll point to where those are in the next page. But it's a nice litmus test. It's not a prerequisite for companies to go through Connectathon, but many or most of us do, because it's a great chance to test with all of our partner systems. And for you on the purchasing side, it gives you some confidence that the vendor doesn't just think they've followed the specification correctly. We've had some third-party adjudicators confirm that things are working as they should. So this is roughly what an integration statement looks like. At the top, you'll see a description of the system, the product name, the version, and that's important. And then there'll be a list for each profile on the left, what the profile is, in the middle, which actor they've implemented, and for some of the profiles, they have options, and if they've implemented those, they can list them there. And so, for example, in this case, this Echo product supports both scheduled workflow and can be used for encounter-based imaging, as well as apparently burning CDs and synchronizing its time clock. To find the document, you can go to the IHE.net website, and if you click through to radiology and scroll down to supplements for trial implementation, you'll find the encounter-based document. I noticed at the start of the webinar that a link has already been put into your webinar interface. So if you can find that in your right-hand box, you can actually click there and get the document as well. Game of Thrones may be over, but Connectathon is coming. So any of you who are on the vendor side, you can start working on implementation. The next opportunity to test will be January of 2020. So this coming January and this coming April. So as Ken was describing earlier, we've already tested a couple of products for the point of care ultrasound. And we hope to test a bunch more with the lightweight modalities in this coming year. If you do start digging in and reading, and this is the last slide of the presentation, you might want to start in the concept section, 47.4.1. A bunch of them, I think there's about 16 subsections. It kind of walks around some of the intricacies. If you're finding you're getting bogged down there, then fine, skip back to the actor descriptions and the transactions. But there's a lot of useful framing concepts in there, so you may find it useful to start there. And don't overlook the cross-profile considerations. Part of the idea of, standards in general and IHE in particular is that once you start using standards, they start cross-linking in all kinds of ways. So for example, you can burn your encounter-based images onto a CD, or you can transfer them to another hospital using XDSI if you want to do it electronically. So there's a lot of ways you can link this into other profiles. The links are there to go look into the product registry, which I don't think we'll have anything yet, because as I say, anything in the product registry is actual released product, but it's and points to their integration statements. Connectathon results tells you what's in the pipeline. Search the vendor websites; they've all got IHE integration pages. Google, of course, is your friend. They'll Google for the name of the profile and see what comes up. And finally, in closing, ask salespeople that if we do have it, they're happy to say yes. And if we don't have it, that's part of how profiles get on product roadmaps. If they get a whole bunch of people saying, we want this, then they respond to that. So at this point, I think we'll hand it back to Jason, and I think we open the floor for questions.
There we go, just unmuting myself again. So yeah, thank you very much, Ken and Kevin. That was a terrific session. We have a bunch of questions that are coming in. Again, just a reminder, if you want to submit your questions in the chat window, that would be fantastic. Maybe before I start out by asking questions, there was a comment that was made by Christopher Roth, Chris Roth from Duke, and he just asked me to share kind of a sentiment. He had to jump back to clinical care. So I'm basically quoting him in this, is commenting as the co-chair for the IHE Radiology Planning Committee, and as a long-time participant in the HIMSS-SIIM community, I want to give kudos to Kevin and the rest of the volunteers in the IHE Radiology who have brought enterprise-based imaging workflow with point-of-care ultrasound and enterprise-based imaging workflow with lightweight to reality. The IHE Technical Committee moves the needle on standards and process gaps we on the front lines of the hospitals struggle with every day, thanks to our IHE Technical Committee volunteers. So that's from Dr. Chris Roth, really nice sentiment there. And then just moving to the question, so there was a question that came in from David Brown, and the question is that traditionally HL7 ORU was selected as the communication method to notify the encounter manager to image availability to the EMR. Could DICOM image availability notification also be used? what are the strengths and weaknesses of each of these approaches?
So that one, I note that we've got 5 minutes left, but so we were leveraging a few different profiles at the same time that wanted to communicate imaging results to the EMR. And so we decided we'd try and get a little bit of synergy going by converging on the ORU as the transfers. So we mentioned earlier that IDAP, oh wait, no, sorry, different call this morning. So import and display of external priors is another one. It's essentially cross-enterprise prefetch. And so there's a few different cases where the EMR needs to be brought into the picture. And the one that best met those converged requirements in the existing install base was the ORU. Now, as mentioned, DICOM does have an instance availability notification service. And for systems that are working within the imaging space, it's more fine-grained. It gets down to specific instances. So the ORU message has the strength that most EMRs support it, but the ORU does not get down to individual data, sets of data instances. It just says essentially that the study, or in some cases the series, exists. So I think if you're looking, for example, at driving like an AI processing system or something, the instance availability would be a better tool for that.
Okay, terrific. We have a question from Kevin McGuire. He says, did you, and I think this is more directed towards Ken, regarding the experiential process at Mayo, but I guess the question is, did you build your own encounter manager, or did you acquire a solution?
Yep, so interesting. We haven't obviously implemented the exact implementation here since this is very new, but we have something very similar. We have a product we built it here. It's called the Image Manager, and it is performing the role of the encounter manager. So what happens is when we've kind of broke down encounter-based imaging into 4 different groups, and I'll just simplify to say that in general, the solution is we intercept the images en route and pause to interact with the encounter manager to collect an accession number. We also went with the accession number as the key, and then index that and then it'll create an order. We actually work with, if we have an Epic EMR that we implemented, so Epic wants orders, so we have a process that the encounter manager is doing on behalf of us to create a record in the EMR. So it's it's like, instead of using the ORU message going back, we have our own message that we created that communicates that exact information and lets the Epic create a record for that, know about that, and passes that accession number, patient ID, so they can link and open up the viewer. So it's not as I've think about this, as we look to reinvent our current solution, we're about to do that because the database it's running on is obsolete. We are probably going to look to use this kind of a workflow instead, although it accomplishes what we're doing, accomplishes exactly the same thing. One final comment on that, the accession number took us a long time to land on that because accession numbers were not unique. As we converged all the different radiology departments and stuff, there were lots of overlapping accession numbers. We finally came back and said the pair of the accession number plus the patient ID is unique. And what we did was went back through the enterprise imaging, and this is hundreds of millions of images. We assigned historical accession numbers in the encounter-based type of imaging where they didn't exist. So in the VNA, every single imaging study has an accession number now, and Epic knows that accession number, and they were backloaded for that. So that's the solution we ended up with looks a lot like this in the end, but it didn't use the protocols that are defined here. But this looks like a nice way to go.
Okay, so unfortunately we are up against the wall with time. We have many really great questions here. So what we're going to do is Ken and Kevin have been gracious enough that they are going to review these questions afterwards, and we're going to see if we can answer them via a blog post through SIIM. So stay tuned for that, so your questions will not go unanswered.